We're going to talk about pleural effusions. Pleural effusions are fluid in the pleural space. There are two types, transudates and exudates. Transudates are an ultrafiltrate of plasma that leaks passively into the pleural space. Transudates are caused by increased hydrostatic pressure, such as in CHF, or decreased oncotic pressure, such as in chronic kidney disease, kwashiorkor, or cirrhosis. Exudates are an active process where something is actively being put in the pleural space, such as an infection, which is called a parapneumonic effusion if associated with pneumonia, TB, malignancy, infarction caused by pulmonary emboli, autoimmune processes such as RA or lupus, or pancreatitis. Exudates can also be from leakage of various structures. If the thoracic duct leaks chyle, it is called a chylothorax. Blood is a hemothorax, and then there is esophageal rupture, which usually leads to a left-sided pleural effusion. Diagnosis starts with a chest x-ray. Lateral decubitus x-ray can be helpful as fluid is gravity dependent and may move with position. Ultrasound may also show fluid in the pleural space. It can be more sensitive than x-ray and show much smaller amounts of fluid. Finally, CT scan can be useful in showing small effusions, a tumor underlying a malignant effusion, and can help to determine whether the fluid is loculated or the pleura is thickened. Loculations occur when fibrin in the effusion cordons off the fluid. If the effusion is loculated, you need to place a chest tube. If this doesn't resolve the effusion, TPA and DNase can be used to break up the fibrin loculations within the pleural effusion. Finally, surgery, such as VATS, can be used when other treatment options are exhausted. If not loculated, treatment depends on whether the patient has CHF or not. If they have CHF, try diuresis first. If the patient doesn't have CHF, and the effusion is at least 1 centimeter, the patient should undergo thoracentesis to drain the fluid. Recurrence 2 to 3 times warrants pleural biopsy. Pleurodesis, or scarring of the pleura, can adhere the chest wall to the lung and prevent recurrent pleural effusions or pneumothoraces. Pleurectomy, mechanical abrasion, and TELC are options. However, TELC should only be used in case of malignancy. Treatment of the underlying etiology is of course also necessary, including antibiotics for infectious pleural effusion. Once fluid is obtained, either from chest tube placement or thoracentesis, there are a number of tests that should be run. What tests, you may ask? What to do with the fluid? Send to cytology to rule out malignancy. Get a cell count with differential. A high white count suggests infection, and high lymphocytes suggest TB. If TB is suspected, adenosine deaminase is another test that can suggest TB, as well as acid-fast staining. Gram stain and culture should always be sent in case of infection. Glucose is also sent as glucose is consumed in infection, and glucose below 60 or pH below 7.2 suggests infectious etiology. Triglycerides suggest a chylothorax. Finally, LDH and total protein should be sent to determine Light's criteria. At the same time, serum LDH and total protein should be tested, as they are also necessary for Light's criteria. What are Light's criteria? Light's criteria helps to differentiate between transudative and exudative effusions. If any of the following is true, the effusion is exudative by Light's criteria. These are LDH of the fluid greater than 2/3 the upper limit of normal for serum, an LDH fluid to LDH serum ratio of greater than 0.6, or a fluid total protein to serum total protein ratio of greater than 0.5. Thanks for watching. Please like, comment, share, subscribe, and hit the notification bell for more great videos. Remember, if you don't want to miss it, look below and click it. Check the description for more great study resources.